And what I'm going to do is introduce Project ECHO and talk a little bit about age-friendly health systems, which is really an underpinning of a lot of what we talk about at ECHO. So just to walk you through what the next 15 minutes or so will contain, I'll talk about some of the context of Project ECHO-Geriatrics, describe age-friendly healthcare, particularly as envisioned by the Institute for Healthcare Improvement. And then I will talk about some of the nuts and bolts of ECHO participation for those of you who are new. So what is ECHO? ECHO stands for the Extension for Community Health Outcomes. Project ECHO is a model of education and telementoring and community learning that was developed by Dr. Sanjeev Arora at the University of New Mexico. He's a hepatologist, and he had this problem where there were many, many patients with hepatitis C who had very, very long waits to get to him. And the patients were having to travel long distances, wait a long time, and were very sick and got sicker while they were waiting. So he had this idea where he was going to train primary care providers to provide specialty care for patients with hepatitis C through a platform similar to what you're experiencing today. Through Zoom, he and an expert panel at the University of New Mexico trained primary care providers through mini didactics and case-based learning of real patients in the care of hepatitis C. And they found that the patients cared for by their own primary care providers who were trained through this program was equivalent, if not better, than those who went all the way to the academic center. So this success of the model really led to an explosion of ECHO. And this, as of last year, is the number of ECHO sites throughout the world. There are ECHOs in a variety of topic areas, not just hepatitis C, but many others that I'll talk about in a second, but it's in over 35 countries. There are hundreds of ECHOs in the United States. And it was utilized extensively during the COVID-19 pandemic, and still is, to rapidly disseminate information and to get people all on the same page. And like I said, it's utilized for many specialties. Geriatrics is one of those. We were one of the first geriatrics ECHOs in the country. There were fewer than 10 when we started, and now there are dozens. So it's really great to see this being utilized more for geriatric medicine as well. And why Project ECHO-Geriatrics? Well, it's not new information to any of you, I'm sure, that the number of older adults in this country and throughout the world is rising. And this rapid rise that you see between 2010 and 2030 is the baby boomer population. So that's why you see that steep curve. But we have a lot more older adults in this country. But we don't have a growing number of geriatricians. There are only about 7,000 geriatricians in the United States, and that number is not rapidly growing, but we have a lot of older adults who need care. So most of the care is being provided by non-geriatricians. So it's good for all of us to know the essential principles of evidence-based care for older adults, and that's the reason behind Project ECHO-Geriatrics. So we launched in January of 2016 and have been running monthly since then, always the third Friday of the month from 12:30 to 1:30. And each session, as you'll see today, has a mini didactic that we record and put on our website that you can view later, and those last 15 or 20 minutes. Some time for a discussion, and then the rest of the time, the meat and the heart of ECHO is case discussion. Presenters from all of you from the region providing a case presentation on a patient that they're struggling with, a patient where the interprofessional discussion would be helpful. And that's how we all learn together and develop this community of geriatrics expertise. So why Project ECHO-Geriatrics? You know, I said there are a lot of older adults in this country, we all know that, but the care they're receiving has a lot of room for improvement. Healthcare for older adults has a lot of very clear deficits in this country. For example, over 30% of older adults are prescribed potentially inappropriate medications that contribute to cognitive impairment and falls. Falls are really common in this country. Over 2.8 million injuries are treated in emergency rooms annually, and there are over 800,000 hospitalizations for falls every year, despite the fact that many falls are preventable. And only about half of those people who have dementia are actually diagnosed with it, which makes it very difficult to do advanced care planning or to provide evidence-based care. And this happens even though older adults spend a lot of time in contact with the healthcare system. On average, an older adult in this country spends 17 contact days engaged in healthcare. That could be clinic visits, visits to the lab, hospital visits, all of the things included in healthcare. So it's the content of the care, not the quantity, that's the problem. So in response to this, the IHI, Institute for Healthcare Improvement, and the John A. Hartford Foundation got together in 2017 and said, we need to do something now to improve the care of older adults. And they launched the Age-Friendly Health Systems Initiative. And I'll spend a few minutes talking about what that entails and the framework they set forth that's useful for all of us in thinking about the care of older adults. So what is age-friendly care? Age-friendly care follows an essential set of evidence-based practices. It's grounded in what we know from the evidence, and it's distilled down to the 4 M's I'll talk about in a moment. It causes no harm, and it aligns with what matters to the older adult and their family caregivers. So the care is matching with what is most important to that individual and their caregiver. The 4 M's include what matters, medication, mentation, and mobility, and I'll dig into what those mean in a second. But where did these come from? They did not come out of thin air. The IHI and Johnny Hartford Foundation put together a group of experts, and they really looked at the fact that we have a lot of evidence-based models of care for older adults, things that prevent delirium and prevent falls and optimize quality of life and care for people with dementia that have improved health outcomes, but very few people who are eligible for them actually receive them. So there's this growing gap in between what we know, the evidence base, and what's actually happening for older adults. So to close this, they looked at the literature to see what can we do to make these age-friendly principles get to older adults more rapidly. So they looked at all of these models of care that can do things like prevent delirium and prevent falls and optimize care for people with cognitive impairment, and looked to see what are the care features, what are the qualities of these models of care. And they distilled it down to 13 care features that are common across these different models, things that seem to be the same across these models of care. And then they realized no one's going to remember 13 M's. So they distilled it down to the 4 M's, the really most important elements of care for older adults grounded in the evidence. And that's where these 4 M's came from. They took the literature and distilled it down to what's most important in the care of older adults. So in looking at these 4 M's, what matters refers to knowing and aligning care with an older adult and their caregivers' goals and their care preferences. And this is across sites of care, and it does not just refer to end-of-life care. It's what matters now. What is most important to you? Is it walking your dog? Is it spending time with family? Is it living in your apartment? Is it volunteering at the local fire department? Whatever it is, let me line up your care so that you can do that. Medications, we try to avoid medications when we can, but if we have to use them, we want to use age-friendly medications that don't get in the way of what matters in mentation and mobility. For mentation, this refers to preventing, identifying, and treating dementia, depression, and delirium, and this is across all settings of care. And mobility refers to making sure an older adult can move safely and maintain their function. So this is fall prevention, but also making sure you're optimizing someone's functional status, their ability to provide their own self-care to live independently. There are a few key points to providing age-friendly care, and the model of the 4 M's is meant to be a framework or a paradigm of care for older adults, not a separate system of care or something you throw on top of what you're already doing, but really a framework for thinking about the care of older adults. So every older adult has all 4 M's assessed and acted upon in every setting. And they can be implemented across an entire healthcare system. You can go big, or you can just do it in a single clinic or with an individual provider in order to provide the 4 M's. Anything is better than nothing. And you should incorporate this into what you're already doing. So your clinic might already be doing fall prevention or cognitive screening. You might be doing annual wellness visits. So you can integrate this into the systems you already have in place rather than, changing everything up. And the tools you use to implement the 4 M's, to assess and act upon each of the M's, there is no specific tool you have to use as long as it's grounded in evidence and it fits with your care setting. So there's a lot of flexibility. There were 5 pioneering health systems that tested out this 4 M's framework, and some are familiar to you. Some of you work in some of these systems. We often have folks from Kaiser and Providence on this call, and they pioneered this, and it's been spread throughout the country through many, many health systems and clinics. So how are the 4 M's operationalized as originally envisioned? For each of the 4 M's, you have to assess them and then act upon them. It's not just enough to do fall screening if you don't have a plan for following up on that, for example. There's a great guide to age-friendly health systems on the IHI website. They have a lot of great materials to help you in providing care with the 4 M's for your patients. So I encourage you to take a look at this guide because it has a lot of great tools and ideas for integrating this into the work that you do. You can also get designated as an age-friendly health system, your individual clinic or your whole health system, and you can apply for that status, and then you're listed on the IHI website as being age-friendly. So let's go back to Project ECHO-Geriatrics. I talked about age-friendly health systems because those 4 M's really are threaded through a lot of what we talk about in our didactics and in our case discussion. So I wanted you to have that framework so you know what we're talking about when we refer to the 4 M's. In order to provide excellent geriatrics care, it really takes a team. There's a lot of complexity, and it really takes utilizing all the members of the team to work together. And that's what we have with our expert panel for Project ECHO-Geriatrics. We have people from the Area Agency on Aging who are really expert in how to help people age in place and what the community resources are. We have a clinical social worker, gerontological nurses, geriatric medicine physician, geriatric pharmacist, and geriatric psychiatrist who all work together to provide recommendations. But the other part of the panel is all of you, because you have a lot of expertise to bring to each of these cases, and I've learned so much over the last 5 years. So cases are the meat of ECHO, and we encourage folks to present cases. The case form will be attached every month with your reminder for ECHO, and just a few notes on the cases. It's great if they're ambulatory primary care focused because it is central to a lot of what we talk about in ECHO, but it doesn't have to be clinic-based if you have a challenging case otherwise. Anyone can present. We often have family medicine residents present. We have some faculty present. We've had speech therapists present. All members of the interdisciplinary team are welcome to present. Trainees are welcome to present. So it can be absolutely anyone presenting. Our case form is comprehensive, but don't be intimidated by it. If there are sections that you don't have the information on or aren't relevant, you can leave them blank. Just make sure you de-identify everything. If we can get the cases 48 hours in advance of the session, we appreciate it, but it's not a hard stop. And we would love to get a case from each of the residency sites that participate throughout the year, and any of you participating are welcome to present. We do send a resource email after each of our sessions so that you don't have to furiously write down the resources that panelists and participants in the region share. So we try to grab all of the most essential ones and send them out to you after the sessions. And just a few final nuts and bolts for ECHO participation. I love to see your faces on video if you can. I understand you can't always do that, but if you can, it's really great for community building, for us to learn together, to be able to see each other. But of course, please try to mute when you're not talking because there ends up being some background noise, but video's on always if you can. Please invite your entire team to participate. Your whole team from clinic, medical assistants, nurses, physical therapists, anyone who wants to attend is welcome, and it just really enriches this discussion. And this is an all teach, all learn model. As I mentioned, all of you are part of the expert panel because we all have things to bring, experiences to bring, evidence we know about that we can share for the cases. So please jump in and offer recommendations and thoughts, and that's the best way for all of us to learn together. So that's what I have to say about ECHO and age-friendly care. I really appreciate all of you participating, and I look forward to getting to know those of you who are new. I look forward to getting to know you better. I really truly believe that together we can make healthcare more age-friendly, and we can do it now instead of in a decade. So thank you so much, and I'm happy to answer any questions that you have about ECHO or age-friendly care or anything else.